Hello, and welcome back to the second stop on our whirlwind tour of the cognitive and emotional facets and aspects of substance use. And today we're going to be looking at a familiar friend or foe, depending on how you look at it and where you sit on the topic of marijuana. But the idea is today to give you sort of a brief overview of the neuropathology as well as the sort of cognitive, emotional, behavioral consequences of acute use, recurrent use, and of course, everybody's big question is the residual effects. If you're consuming marijuana products for an extended period of time, does our brain bounce back? And what might be the risk factors for residual impact? When we talk about cannabis, the main the main focus we really want to look at is one of the molecules within marijuana products, which is THC. And THC is associated with increasing dopamine within the mesolimbic pathways of the brain. So again, this is the limbic system that we talked about medially, in particular structures near the cingulate cortex within the brain, and heavy hitters like the amygdala, the thalamus, the insula cortex. These are areas that are definitely involved in the processing and regulation of emotion. And also, like we talked about yesterday, when I released the first of our many videos in the series, is talking about how it impacts reward response. And THC certainly activates that. One of the things we talked about in terms of those supportive players is GABA and glutamate. And glutamate being the most active, agonizing neurotransmitter, the excitatory neurotransmitter in our system, and its cousin GABA, the inhibitory flip side of things. And glutamate in particular, they've thought that augmenting glutamate levels due to THC may account for that analgesic or pain-reducing effect. And it also might lead to the unintended consequences of impacting motor coordination and, of course, sensory perceptual disturbances. And again, for THC, depending on the strain, depending on the individual, it can have a whole host of different neuropsychiatric effects. For some folks, it tends to be sedating. It tends to be numbing and emotionally flattening. For others, it tends to be an exciting substance where it actually creates more of a almost like a hypomanic state in terms of being very easily shifted by positive and negative emotions. You're more active, engaged. It just depends on the individual. And that's the sort of beautiful mystery of cannabis, is that it impacts people so differently. It's not very predictable in the same sequence as it does for alcohol. And the acute effects, like I just talked about, are typically euphoria or sedation. And depersonalization is one of those that is a major point of sort of dilemma for how clinical psychologists help folks that recurrently use marijuana. And that is because depersonalization, or the idea of sort of stepping out of one's body or kind of perceiving oneself as strange. Oftentimes it's accompanied by derealization. The idea, again, in these two concepts together, of kind of seeing things in like a dreamlike state. Everything kind of seems surreal. That sort of out-of-body or surreal experience that happens with marijuana can induce anxiety for some folks. So it becomes this trade-off of, well, it's kind of anti-inflammatory, it can reduce pain, it can calm and sedate people, but for others, it becomes a big trigger for anxious arousal and actually has an unintended effect of making them more panicky, more mood dysregulated. So something to keep in mind. And the analgesic effects are really one of those ones where there's a lot of interest. You know, how do we kind of reduce opioid dependence and reliance within the medical field, particularly in America, where opioids are handed out by physicians across the country. And a lot of times there's not a lot of sort of background to look at whether or not an individual has an addictive personality, whether or not they're likely to abuse pain management medications. And even though marijuana definitely has some addictive properties to it, it definitely doesn't carry the same risk of abuse, the same risk of self-harm from overdose that you would get with opioid agents. And so it's become an attractive alternative, particularly for those high in CBD, those products that target CBD for that more anti-inflammatory effect with less of this sort of change in mentation or altered mental status that you might get from the THC heavy products. So again, a lot of research going there, a lot of conclusions still yet to be determined. The other thing is because it impacts a lot of those mesolimbic structures, nearby you've got a lot of regulatory structures, the hypothalamus in particular. These centers of the brain deal with, again, like we talked about yesterday, homeostasis. And so, of course, temperature, inflammatory processes, autonomic arousal, different things that regulate us and keep us feeling like us are going to be impacted by different activation of these neurotransmitters. And so THC and CBD seem to have those properties. Now, the biological mechanisms, again, dopamine, GABA, and glutamate are all sort of increased as a result of THC introduction to the body. And it happens pretty rapidly, particularly if one is smoking the substance, right? It's quicker to enter the bloodstream, quicker to be processed, versus, again, another popular form of consumption being edibles. Typically have to make a first pass through the stomach and small intestine and then go through the liver. It takes a longer time for those substances to hit. But of course, when it's consumed in an edible format, marijuana can have a more prolonged or distributed effect over time. And so the half-life is much longer than if you were to smoke it. Nonetheless, as a result, CB1 or cannabinoid 1 receptors are they're impacted by THC introduction to the system, and they have behavioral and cognitive effects like we've been talking about. Now, one of the things that, again, people often ask me, particularly patients, those trying to manage pain, and they sort of, they look at their advancing pain medication regimen and they want to know, well, I take CBD on the side, or maybe I smoke a little bit of marijuana before bed every night. Is there sort of long-term consequences at the molecular level within the brain? And really what I have to say, and what's frustrating, is that the research is very inconclusive. A lot of studies have relied entirely on mouse rodent models. And the reason for that, too, is because of the tight levels of control that we can enact. There are a decent proportion of folks that only smoke marijuana, but again, with a lot of other substances, marijuana is usually used concurrently with other substances. So whether it be tobacco, alcohol, cocaine, pain medications, right? Even things like benzodiazepines for anxiety treatment on the regular, it impacts or confounds our ability to tease apart what are the exact effects due to marijuana alone. So animal models become sort of not only helpful for teasing apart the processes associated with cannabinoid introduction to the body, but we have tighter control. So far, the very sparse research on humans and the well-done controlled studies with animal models have shown that there are minimal consequences for neurotoxic effects, meaning you're not going to be permanently damaging or causing cell death in a lot of these studies. So that's the good side. On the other hand, there are some question marks regarding whether or not structural changes may occur, particularly in those high in CB1 receptors. So again, if we keep introducing THC to the system, and dopamine in particular continues to be activated, how do those structures respond, right? In alcohol, we showed that dopamine receptors actually retract back into the cells. It's a process called down regulation, because the body is saying, hey, we're getting way too much dopamine. We don't need to be having this many receptors there. And what happens is then as a result, because we're not getting as much of a dopaminergic effect, we consume more and more and more to get more dopamine into the system and try to take advantage of the few receptors we still have there. So structurally, the same thing might be possible in cannabis, but we don't understand it that well. There's a lot of heterogeneity in the extant research. And the other thing is there might be damage to neurons. We don't know whether or not, again, that's sort of a partial recoverable damage, whether or not it's mainly, damage to axons, cell bodies, perhaps dendrites are unfairly compromised. What we don't know is nothing's been consistently demonstrated. And the meta-analyses that are available looking at sort of this at the molecular level are inconsistent. So you got to keep that in mind with marijuana. And that's the frustrating part, especially with the legalization efforts and attempts to sort of make this more widespread as a treatment alternative for folks with many medical problems that might benefit from THC and CBD products. So the neurological effects, looking at more large scale, again, these studies are focused on current users. And so for, in both human and animal models, during acute intoxication, there does seem to be some evidence for reduced blood flow in the frontal limbic and cerebellar areas. And again, the idea here isn't that there's permanent damage per se, or that this is a massive amount of potential change to neurological structures. But what is indicated is that when you are acutely intoxicated, there is disturbance of normal blood flow, which seems to be a reflection of neurotransmitter and neurological activity in the brain, that it is altered when you are high. There may be metabolic alteration. So again, different cellular internal processes change within the prefrontal cortex, the anterior cingulate cortex right behind it, more medially and toward the center, and of course the cerebellum as well. So again, if you remember our alcohol discussion yesterday, these are a lot of the same structures involved in those dopaminergic pathways. There is a lot of bidirectional connections between the prefrontal cortex, the anterior cingulate, and then those striatal structures, which also feed down to the cerebellum, involved in reward response, emotional processing, and motor movement. There's also potentially changes in the within the connections between the frontal lobes and the hippocampus, though again, what they've shown with at least the available research is a lot of these structural changes and changes in metabolic and cerebral activity resolve with sustained abstinence. So that's the big kicker, right? Is, maybe somebody has some changes if they're acutely consuming a whole lot. They're heavy cannabis users. But what happens if you pull those individuals away from cannabis and they don't consume anything for a couple weeks and you're able to get them more stable? Well, the existing research says that this is encouraging for return to baseline. But again, we need more well-controlled studies. So I don't want to wave this as a flag for saying there's no way there's consequences. We just don't really know if there are consequences, what they exactly look like from a metabolic and molecular level within the brain. So what does it result in terms of cognitively? Well, acutely, when you're high, similarly to alcohol consumption, you're disturbing a lot of those frontal networks. So things that are attributed to the frontal lobes as sort of the leader in these different domains: working memory, verbal memory, and on the encoding phase. And again, for encoding, we talk about memory really as three different processes. It's really encoding, getting information in, holding on to that information, and then being able to retrieve it accurately when called upon. And of course, as you retrieve information over and over time, what happens is you reconsolidate and find ways to organize that information. So how well does an individual then kind of store that information meaningfully and over time continue to be able to access it? And we know the more and more we retrieve something, the better we get at sort of dynamically storing it and consolidating it for future use. So the front end of it, mainly just getting things into the file cabinet and filling up your folder with relevant information, it's impaired when you're acutely intoxicated. Processing speed may be an issue there, right? So sustained attention and psychomotor speed, meaning how quickly we can register and attend to information, it's definitely suppressed when you're acutely intoxicated. And cognitive control can also go to the wayside, particularly with higher THC levels. So again, you tend to be a little bit more impulsive, and a lot of that might be because of the fact that you can't attend to or process all the different threats in your environment. You're not analyzing potential consequences to your behavior if your processing speed is so slow. And the other thing is that can lead to, of course, risk-taking or poor decision-making because we're unable to attend to all these different issues. Internally, we're just moving more slowly. We're used to going 80 miles an hour on the freeway. Acutely intoxicated from cannabis, you're going 40 miles an hour. So even though you're being asked to get somewhere quickly, the speed limit is 80 miles an hour, you need to get somewhere quickly, you're driving really slow. So you're going to miss certain things on the way there because you're not going at the normal rate of information processing that is inherent to making decisions at a higher order level. But of course, we also want to look at, okay, so what happens on the come down? So say you've consumed cannabis and now you want to know, okay, how's my brain bounce back in the first, say, 3 days? Well, what it's been shown in largely in animal models, but also in human users, is that learning and memory can still be impacted. Executive functioning, which will encompass things like working memory, multitasking, problem solving, all that good stuff that falls under that very esoteric and nebulous executive function domain, can be impacted. And of course, language, and what this tends to be is not comprehension of language, but I believe it's referring more to expressive fluency. And what I mean by that is your ability to effectively and quickly and efficiently communicate information. It's about how quickly you can retrieve words and get them out in a meaningful manner to somebody who's a recipient target. And oftentimes a good way to test this, we have patients generate words as quickly as they can based on a certain letter of the alphabet. So I say, tell me every word that you can think of that starts with the letter D. So then they have 60 seconds to tell me as many words as they can think of. That's what we call phonemic fluency. It's a form of expressive fluency that takes the frontal lobes in terms of how quickly we're able to kind of organize our thoughts and get things out in terms of verbal production, but also pulls on the temporal lobes for semantic knowledge. We have to be able to go, okay, we need to run through our language bank to come up with relevant words and then pull them out quickly and efficiently and produce them on command. So that might be a way to study that. And variably, attention and psychomotor speed can still be a little more sluggish than at baseline 72 hours beyond use. Now, the big one is the variability. And this is the one that really stinks for us as researchers because we don't have a good profile for what cannabis use looks like. The best I can tell you is the most vulnerable domains based on the research I've looked at, and there's a lot of good meta-analyses and systematic reviews out there, but again, they speak to the heterogeneity of findings. So I want to caveat anything I'm about to say with, it's going to vary by population, it's going to vary by user, it's going to vary by amount and frequency of use. I mean, there's so many different individual variables that come into play here. There's not a good profile. But I will say the best things to look at will include, again, new learning and encoding information, problems with retrieving information effectively, and psychomotor speed, processing speed, attention, working memory. These are areas that tend to be just a little bit lower over time with recurrent use. And when they say memory deficits, because I have seen some things in the media where they're talking about, oh, this study showed that patients have memory problems after years of cannabis use. A lot of those studies don't, at least with those attention-grabbing headlines, talk about which domains of memory. And again, if we're talking about the 3 different processes I just mentioned, marijuana users seem most susceptible to having problems on the front end in terms of getting information into the correct folders, as well as pulling out the correct files from their filing cabinet. They have retrieval deficits, but they're not amnestic. So for example, an Alzheimer's patient, right? Prototypical individual who has an anterograde amnesia, right? They can't remember things after 5 to 10 minutes. They have problems getting information into the folders to begin with, but even for the little information they do get in, most of it is not filed at all, or the filing cabinet is altogether lost. They can't even get to the right room where the filing cabinet is. It's gone. It's out of memory. For marijuana users, they have problems getting information in potentially into those folders, but the cabinet's still there and they know the cabinet's still there, but they're inefficient and tend to have problems pulling out the right files without assistance, what we call queuing or scaffolding from the examiner to pull things back out and retrieve them accurately from memory. So those are the areas where they seem to be most susceptible based on the literature I've looked at. Again, as we get more and more studies, and particularly as legalization status changes, this is going to be something that we're going to continue to pay attention to. And so then what happens with abstinence? Well, there is minimal evidence to date of permanent structural damages. Again, I say minimal evidence because any data that is out there tends to be conflicted. There's positive, for example, one study I saw, I think it was in mice models, and it was done within the last 5 to 10 years. It showed that for alcohol-consuming mice or rodent models, marijuana actually, when administered concurrently with that, actually had a neuroprotective effect from the negative metabolic effects of alcohol. And I was thinking to myself, wow, that's fascinating. Marijuana could be this protective agent. But again, it's used in a very, very controlled setting with an animal model. And we don't really know at what level marijuana is neuroprotective versus increased risks for neurologic changes within the brain. So there's minimal evidence to date, but that evidence is inconclusive. And most cognitive domains, as I said, even in heavy recurrent users, do recover with sustained abstinence. Now, there's a high level of relapse among marijuana users, and also the deficits that will remain, not romaine, we're not talking about lettuce here, the deficits that will remain for these users, the heavy recurrent users, they can still be mild. And it's going to, again, depend on the individual, depend on things like baseline level of cognition. For lower functioning individuals, maybe the deficits aren't as obvious, but for higher functioning folks, with high levels of academic achievement, higher levels of intellectual functioning, they might notice those more subtle changes from heavy use. So again, it depends a lot on those moderating consumer variables. And the metabolic changes, I will say, it seems like those do reset with abstinence quicker than maybe the cognitive domains return to baseline. The complications that we need to pay attention to is sort of my final word for this section, is that adolescent use is definitely associated with worse outcomes. As I talked about yesterday briefly, the frontal lobes are not done fully forming and sort of correctly integrating different synaptic networks until oftentimes mid-20s. And because of this, and because the frontal lobes are forming, again, through adolescence, late teenage years and into young adulthood, consuming cannabis, which definitely has an impact metabolically at a microscopic level within the brain, it's going to impact the frontal lobes. And so if those areas are still forming and the puzzle pieces are still being set into place, adolescent users are increasing risk for long-term problems because those areas aren't set yet. So you're sort of messing with the construction site while it's still at work. You're playing in that construction site before things are finalized. So again, if you think about it like that, if you're messing with marijuana and a large amount of it, and there tends to be, there is a portion of high schoolers at a younger level, right? 7th, 8th, 9th graders are turning to marijuana in terms of coping resources. They're playing with fire in terms of risk of cognitive and emotional complications because, again, the system isn't set in place, particularly for those frontal systems. And the cognitive impact is still to be determined. And again, for those, while you're high and also acutely following being high, if you're taking a lot, particularly like a heavy dose of an edible, or you're smoking a large amount of THC, you're risking, again, at least acutely, a lot of cognitive side effects that you may not want. And there's also concerns with better understanding at what limit we're actually impaired in doing basic functional things, right? So, for example, we have BAC for alcohol use, right? 2 drinks tends to put you over the line. You can't be drinking. Marijuana use, we don't have a good way of measuring that. And it probably varies a lot like BAC does, depending on the individual, their metabolic capabilities, their weight. There's a lot of different biological factors that come into play. Marijuana, this is still a question mark. You can definitely, absolutely get a DWI due to marijuana consumption for any amount if it impairs your driving and they can detect it or it comes out when it's inquired. But in terms of determining at what level it impairs us at a functional level, truly, there's a lot of variability and question marks there. So again, just things to keep in mind when thinking about marijuana use. So again, I want to thank everybody for visiting my channel. I got a lot of great feedback yesterday in terms of the initial video. I have a lot of passion about substance use and how it impacts the brain. And I think, again, this is knowledge that it doesn't need to be so esoteric and guarded by the mental health community. It's something that needs to be broken down and discussed because it's something where, drug use isn't going anywhere. And things like marijuana are becoming more and more prevalent. So we need to understand how these substances really impact us. And when there are question marks in the research, we don't just say, oh no, it's nothing to worry about, or everything's fine. We need to be open with saying, no, there's question marks there. There's uncertainties in the data, and we need to own up to that. And that's what I do with my patients, or at least I try to, is to say, hey, you're taking this CBD product. It hasn't been officially documented as an empirical resource for something like pain management. There's supportive literature out there, but well-controlled, effective science, it still has a ways to go. So I say you're taking your own risks. There are cognitive and emotional consequences to it. And I think everybody deserves to have that education about it. So anyways, I appreciate your time. Again, my name is Brad Reynolds. And I, again, thank you for tuning in. And next, as a preview to cocaine, which again, as a potent stimulant, remains very popular, particularly in those higher socioeconomic, particularly among white males, a substance that is abused. And there, besides the short-term effect of maybe enhancing things like attention, There's a lot of consequences to cocaine use. It is not it's definitely not one without residual impact on the brain. So we'll talk about that next. Anyways, everybody, again, stay safe. I hope everybody's doing well. And again, thank you for tuning in. Take care.